Greetings to our ACAM members, friends, and visitors. Welcome to another eMedTalk. The format for today will be an update on coronavirus, COVID-19 from Dr. Herskowitz, an introduction of Ryan Smith, and followed by a speech presentation, and concluded with a summary and question and answer segment moderated by Dr. Herskowitz. So please submit all the questions to the right in the Q&A box. And so next, I'd like to introduce Dr. Herskowitz with an extensive background in immunology, autoimmunity, and virology. He leads ACAM as his president, and I am going to be passing it over to you, sir.
Thank you, Jordan, and good afternoon, everyone. I think that at this point, we want to have an overview of where we really are first, and then we can go into long-term strategies, which I want to bring in one of my colleagues from TAILOR MADE Compounding Pharmacy, which has the handle on peptide therapies and how they can immunomodulate us in a protective way. So, but in the first order, I wanted to just review where we really are. So I'm going to go to my slides now and provide a perspective. I started this perspective in last week's webinar, but we'll do it again in a more summary fashion. So when you look at where we are, we're roughly at 25,000 deaths in the United States, and we'll get into the demographics in a few minutes. But, well, we have the following leading causes of death, and some of them are highlighted because heart disease and cancer represents about 1.2 million of the total 2.8 million deaths in the United States annually. But the other ones that are highlighted are influenza and pneumonia at 56,000. And again, right now with COVID, even though majority of patients that have died have had comorbidities of varying different kinds, it's still more than 2x our annual rate of influenza and pneumonia is more than 2x what it is right now. And also, I also highlighted suicide because we all know that there will be collateral damage from this isolation approach. But please remember the numbers of 1.2 million, and then we can go ahead. So we have 2.8 million deaths in the United States, and roughly that's 900 deaths per 100,000. But at this point, if we had 1% of our annual death rate from COVID-19, we would reach the 30,000 mark. So we'd roughly have, I think, 28,000 some odd deaths, and which we will reach more likely than not. But last year, seasonal flu caused double this amount of mortality. Sorry. So we're roughly about half of where we are for all of last year's seasonal flu. Of course, we're just ended the first quarter, but just to put it in perspective, this really needs to be understood. When you look at the data in different ways, you realize that while we lead the world in mortality, when you look at the right-hand column here, we have roughly, as of yesterday, roughly 1 in every 15,000 Americans has died of COVID-19, roughly 5 times less than certain other countries, the Italy and Spain, ones that you've all been following, and roughly 3-4 times the difference and double the difference, or half the difference, excuse me, as the United Kingdom. So we are less per capita than all the European nations. There are other European nations, smaller ones, Netherlands and Belgium, which much higher deaths per unit of population. So relatively speaking, because the country is so vast and we have pockets of cases, or clusters, so to speak, is the term I'll use later, in New York State and New Jersey and so on, in the East Coast, that we are less than other folks are. So when you look at the domestic deaths per capita, again, New York City is by far driving, and New York State is driving around half of the cases, and around half of the deaths, with New York and New Jersey roughly 50% of all the deaths in the United States, and again, roughly in the same numerical values as seen in Europe. So we have one hotspot in New York and New Jersey that's roughly equivalent to the countries of Italy, Spain, and the United Kingdom, and France for that matter. So relatively speaking, though, when you look at the difference between New York State and California and Washington, Connecticut, and all these other states, this is, the death rates are obviously a lot less, and the rates per population are also a lot less. And notice, please, in California, it's 1 in every some 60,000 folks, which is roughly 30 times less than the rate in New York State. So we have a regional set of issues. We have clusters that are, and our ground zero remains in to our colleagues that we are so grateful for taking care of all the folks in New York and New Jersey, and as well as the other states. One other thing that comes up when you look at Washington is that Washington was the first state in the West Coast to have cases reported, and they reported mainly a large cluster in one nursing home and one hospital. And then after that cluster subsided, the cases subsided over time. And the concept of multiple clusters is what we're going to be talking about for the future. So keep that in mind. When you look at who gets this virus, this is one of the most important pieces of information that we can keep in the back of our minds. The best data, I feel, come from South Korea and Italy, where we can really trust the data. In the United States, there is, it was difficult to find the data for today's webinar, so I apologize for that. When you look at this, you notice that in the 60+ age group, it's roughly 25% of all the cases, that's test positive cases, are in the 60+ year group. That means 75% of the cases that are reported are below 60 years of age. And, but the death rates in 75% of the population that tested is roughly 1%. In the other population, which is 25% of the people tested, the death rates go up dramatically, as you all well know, back into the 70+ age groups. And this data is reproduced almost to the point in Italy. So in Italy, again, it looks like it's a superimposed model where 3% of all the cases of mortality are below the age of 60. They also have this population that they've even subdivided into 90+ year olds. Again, whether you're 80 or 90, it seems to make no difference. You have a high level of mortality. And the question has always been asked as to why, and there's an astoundingly clear answer to this, and a clue to what integrative doctors have been talking about for the last 20, 30, 40 years. And that's represented here. The virus attaches to the ACE2 receptor, and this is a single receptor that the virus attaches to. It likes to work through this receptor because this is the main way it targets a tissue, and there's a lot of ACE2 receptors in the throat, in the mouth, in the sinuses, and in the lungs, as well as the heart. So, but what does this receptor do? This receptor has wide, system-wide effects. And the fascinating thing here is when you target this receptor, you're not only targeting people who already have a dysfunctional receptor, but you're also making that receptor less functional over time. So when you look at the left-hand column, what happens when your ACE2 receptor diminishes in both number and activity? Well, you get vasoconstriction, you get scarring, you get hypertrophy, you get proliferation, you get atherosclerosis. You get less, you get more fluid. And the other thing that isn't written here, it's under the proliferation, you get immunological dysfunction. So you get this out of control hyperinflammation state that we see. So this is why half of all the patients that died from China, we know, and certainly from Italy as well, already had high blood pressure. They already had diabetes. They already had heart failure in particular, as well as some smaller fraction that actually had primary lung disease. So that's because this receptor was already dysfunctional, and this receptor then became even more dysfunctional, so that their system, their entire system biology suffered dramatically, and that's why they have so many difficulties to get over an inflammatory state, which is in the lung and in the heart. So this has been going on now for a month or so in the United States, and the question is, where are we going, and what is the dialogue? The dialogue has shifted in the last week from the overwhelming burden of cases in New York and in certain other states and locations to the following. So here you see the mortality rates in New York State and in New York City, and it looks daunting, and it looks like it hasn't been changing. But in fact, I'm going to go to a different screen. Things are actually looking a bit better. And this is a slide that I hope you can see. And this is a slide from a website that I had talked about last time. This website, if you can photograph it, you can get into there and play with the data on your own. In this case, it's New York new deaths per day, and you notice that what Governor Cuomo has been saying, and that there seems to be a flattening of this curve. And when you look at the new cases per day, there's a flattening. And when you look at recoveries, the recoveries are going up. So this is why we more likely than not have reached the peak in certain locations and in our ground zero location. So this curve is going to flatten out over time, because as you get more people recovering, as you get fewer and fewer cases and fewer people dying every day, then that's sort of the next step. So now we're into a different dialogue, and that is, how do we get released? What is the exit strategy? Well, the exit strategy is buffered by this fear of a second wave. So when I read the news yesterday and looked into it, I listened to BBC and NPR and CNN and so on, and I heard that, particularly with BBC, that Singapore is now in lockdown again, and so is Osaka and Tokyo with their second wave. And I was surprised by that, because I have colleagues in each of these locations, and they didn't tell me anything about this. They didn't warn me about this. When you look at the data from all these websites that do track day-to-day activities, there's no indication of this. So I don't exactly know what the trigger was for Singapore to go on lockdown, and Osaka and Tokyo, but there's actually no indication that they would be doing so based on an overwhelming set of second cases. So at this point, I would say that it's rational to believe that a second wave hypothesis has not yet been seen clearly, nor has reactivation of virus have been seen clearly, and we'll have to watch it and see. I do think that the general sum of all the information suggests that we'll be reopening certain parts of the economy in May or June, but we'll be aiming for the third quarter. And then you have the other side, and it depends on what region you're in, but then you have the WHO warning, oh, this may be too soon, and this may be too soon, and we'll have to wait. I'm, I think, one of the few individuals that not only does integrative medicine, but knows virology and immunology, but also worked with the WHO, and for that matter, worked with the Gates Foundation closely for 8 or 9 years. And I can say that this is what the WHO does. This is their job. This is their job to say that we have to be cautious and overly cautious, and and we will need to rely on the vaccine ultimately for the miracle exit strategy. And I think we'll be discussing this in a minute. But we do know that Taiwan is a success story with total remission But in that setting, it'll be hard to, it would be really hard to execute this in the United States because of the total control that the government has on everyone's whereabouts. But in fact, we know that this system worked. In Korea, where the system is not quite into that, I can tell you from my colleagues in Korea that Korea is around 3 weeks ahead of us in California and probably 4 to 6 weeks ahead of New York. And life is going back to normal. I don't have the photographs of the 50% traffic in the malls and the 80% traffic in the restaurants and in the people walking in the street, but suffice to say that life is almost getting back to normal, and they do have some secondary bumps, but they're relatively minor. And some 50 new cases in a city of 15 million in Seoul is not a dramatic second wave. So how do we get released? I think that we should look at this like chemotherapy. So isolation is like chemo, and it's caused a remission. We know that social isolation has worked, and it's worked dramatically. The question is, how do you manage it over a time period that's suggested to be 12 plus months? So how long do we need to take this isolation? So the latest data from UK, United Kingdom, is that they'll have a vaccine prepared by September, but the rollout for the whole population in the United Kingdom, for that matter, for the United States, would take a minimum of 6 to 12 months afterwards. So how do you protect yourself, and how do you strategize this? Well, yesterday in the New England Journal of Medicine, there was the first paper on the antiviral therapies that have been tested in New York City, and largely to be positive results. Those antivirals are given intravenously, so they're not useful on the oral side. But we will have drug therapies that can treat people who are already ill. We already have a lot of early data from the malaria drug Plaquenil as well as Zithromax that need to be further studied and published and made available. Our own anecdotes here amongst many of my colleagues as well is that the results are strongly positive, and yet we need to implement this on a massive scale. So if you go outside and you get released and you get ill, you should get either stay asymptomatic, or if you get ill, you get a low level of symptoms. And then we have to avoid clusters. And what I mean by that is the lessons learned from Florida. So we had the experiment where the beaches were open a bit too late. And then we had this fascinating graphic come from an entity that could track cell phones and where they come from. And you'll notice that the tracking cell phone, who has a cell phone in Fort Lauderdale, but where they come from. And you realize that these tens of thousands of people are coming from all over the country. This focuses on the East Coast and on the upper mid coast, but it's a fascinating thing. This is what one cluster in a beach in Florida can produce. But now our clusters are much clearer. Our clusters are now our jails and our nursing homes. Sorry about that, our nursing homes. So we have different perspectives now on how we can minimize our clusters. And in California, in San Francisco, our two main hospitals are relatively empty, but our resources now need to be applied to these other facilities that house people that are quite at high risk. So the key gaps, when you look at the international data on the international news reports that are more ahead of us in the United States, because we're still in the what's going on in New York phase versus where we're going to be in 2-3 months. You need to have all these particular steps. Now, these steps we are behind in the United States. We have no surveillance systems. We have no testing at this point. We have very limited testing. We have no contact tracing because we've also diminished our abilities in the public sector. And then we have no antibody testing at this point. We know that the private sector is coming forward with this, and my test that I ordered hasn't come through yet to show who already has had the virus and what antibody titers they have. But what I wrote here is that this is biological insurance. So getting this virus and proving that you have it at a high titer will be a gold standard soon. And so we must learn and teach the concept of immune modulation. And that's why I invited Brian Smith from TAILOR MADE to talk about his approaches to immune modulation, because we need more than just the basics. The basics are vitamin D and vitamin C and zinc. We also used all these others in our teachings over the last few weeks. And we've also pushed the need to have available the hydroxychloroquine and Zithromax, as well as to test those and test antivirals. But there's other things that are well known and well studied, and these go into the immunomodulatory peptide world, that I will now hand off to Ryan, who I find is immensely knowledgeable and straightforward and is an excellent teacher. So I'll give it back to you, Jordan, now, and we can hand it over to Ryan to talk about how to modulate your immune system using sort of high-level types of therapies and under the peptide world.
Absolutely. Thanks so much, Dr. Herskowitz. I appreciate you having me on, and definitely have a lot to talk about today as it relates to some of these therapies. And so real quickly, I'll pull up my PowerPoint presentation, but I also want to just briefly talk about a lot of the things that we're seeing. You know, we're blessed with the proximity to a lot of physicians, and that includes a lot of physicians in the, you know, in the integrated medicine space, but as well as, you know, the infectious disease space, and have seen quite a few things over the past couple of weeks. One of the things I would say we've seen is just a continued interest in peptide therapies as an option to treat these things. You know, MIT got a lot of press recently with the idea that they had the 23 amino acid peptide, which could inhibit the binding of that S spike protein to those ACE2 inhibitors. And so we're seeing a lot there. We're seeing things with furin, which is, you know, a more complicated process in that binding spike, and the ACE2 products as well. And so, so I would say that, again, modern medicine is still turning to peptides for answers. And why we won't talk about those with the coronavirus particularly, definitely want to go over a lot of things that can just help modulate immunity. You know, in particular, but yeah, the other thing I want to reference is just some things about prevention. Obviously, masks have been incredibly difficult to get, and right now the FDA has approved the KN95 masks, which are really the Chinese equivalent of the N95s, and those actually are approved in Europe as well. The only difference between those masks are the pressures that they have to exude on exhalation, with the N95s being slightly better. And so if the KN95s are available, I would recommend purchasing those. We do have a supply of TAILOR MADE as well, and those seem to be right now, I would say, the gold standard in what is available for anyone who's not a hospital or has to deal with any type of splash worry. And so again, I just wanted to lay that out there, because as we talk about prevention, we'll need more than just the immune modulators products. Yeah, these are some of the products and peptides which have been discussed previously. You know, the Thymosin alpha-1 is one I'll belabor. The LL37 is one that I won't. That is going to be, unfortunately, going away here relatively soon due to some FDA changes. But I just wanted to mention it, as you will hear about it and see it. The LL37 is an antimicrobial peptide, the only natural human cathelicidin. And so it is it's still got a lot of practical application, but it will be unavailable, unfortunately. And so the other products to talk about are the Selank, the Thymosin beta-4, and then the Pentosan polysulfate. So to start it all off, I'll start with, you know, just a general overview of the thymosins. In the mid-1960s, you know, Dr. Goldstein discovered these thymus extracts, which had a significant role in a lot of applications in the body. Particularly the two most, I would say, prevalent are going to be the Thymosin alpha-1 and the Thymosin beta-4. And these had a lot of different interactions within the body. The one that we're interested in primarily for immunity is the Thymosin alpha-1, and this is my favorite of all the peptides, just due to how positive it is and how it has very, very few negative consequences. I know this one as well as something Dr. Herskowitz has used frequently in his practice for even things like cancer. And that's actually what it's FDA approved for. It's FDA got orphan drug status in 2013 for malignant melanoma, as well as hepatitis C and hepatitis B. and it has a lot of immune modulating properties and a great safety profile. So it's been studied since 1985, and it stimulates a lot of different processes in the innate immunity process. Obviously, it has some effects on cytokines, particularly IL-12 and IL-2. These are not the typical cytokines with COVID-19 that you experience with some of those comorbid conditions, which can lead to some of that organ damage, particularly those in that cytokine storm most highly expressed are the IL-12, or sorry, IL-6 and IL-1. And then it also increases interferon gamma, which can lead to some of that innate immunity effects, and then obviously stimulates a lot of the CD34, CD4 cells, cytotoxic T cells, and natural killer cells. And then also has an effect on infected cells by increasing the MHC class I expression, which helps these cells identify that they are infected and helps this innate immune system sort of clear out the virus. Another thing that I should mention about this, I should say whenever we talk about the MHC class I, to diverge a little bit, is also the philosophy on NAD. I know a lot of people are thinking about increasing NAD or using some of the NAD precursors like nicotinamide riboside or nicotide mononucleotide, but there are a few studies which show that supplementing with NAD might actually hurt in this virus, because one of the ways that these viruses I should say one of the ways the body can affect these viral replicated cells is by increasing CD38 and depleting the intracellular NAD concentration, and using that as a signal for apoptosis. And unfortunately, if you supplement with NAD+, there's some theories that might become less applicable and therefore less relevant. And so I would say caution on using any of those therapies until we know a little bit more. But going back to the thymosin alpha-1, it's has a lot of different effects due to its effect on the immune system. It can help with infectious disease. It can help tamper down inflammation. We've seen this in autoimmunity. It can help with cancer. It can help with immune deficiencies. And whenever we talk about this vaccine being available, in September, as Dr. Herskowitz mentioned, but without a rollout for probably several more months, the vaccines, particularly influenza flu vaccines, are 35% more effective whenever given with the thymosin alpha-1. And so even as an adjuvant to a vaccine, it's something to consider as well. And then lastly, it has a ton of just general anti-aging, I say, effects as well, because it can sort of help counter that immune senescence which you get as a result of aging. And so again, it can be used for a lot of different things, and just is a great product. In addition to all those cytokine pathways that I mentioned and immune modulating effects, it also has a direct antiviral effect. And I think that was important to note as well. This is a direct quote from its drug monograph, which shows that it can directly depress viral replication and increase the expression of those viral antigens so that they're able to be detected by the immune system, which is also pretty powerful and really the most powerful way to affect the immune system as we think about this. This is also just a great general summary of its mechanism of action. It talks about a lot of the cytokines which are causing, the increase in these immune cell functions and the antiviral effects of the natural killer cells and cytotoxic T cells, as well as the increase in some of those plasma cells. And as I mentioned, it also has a lot of effect in cancer. And this is another area where we see, really good results. Here you can see the effect it has on IL-2 and IL-4, as well as its effect on increasing natural killer cells. This is a colorectal cancer study, but still very, very applicable, because these same immune cells are what are affecting some of its effect for things like influenza, hepatitis C, hepatitis B, and coronavirus. So the trade name that this has is Zadaxin, and they typically would recommend a dose of 1.6 milligrams injected twice weekly. The good thing about the thymosin alpha-1 is that it really has almost no side effects, and I'll get into that in a little bit. But we would recommend this prophylactically as well as a treatment strategy. And so typically our recommended dose is 1.5 milligrams, or a half a cc of our compounded product, just twice weekly. And some people will do it more often when dealing with hard to treat cancers or dealing with something like autoimmune, where people would dose more frequently. But generally, I would say 1.5 milligrams twice weekly tends to be the most consistent dose. We're talking about a lot of the contraindications. I always want to highlight this paragraph toward the end of the drug monograph for Zadaxin, which shows that it's been used in over 3,000 patients clinically with no significant side effects, and has been administered to people over 100 years of age and as children as young as 13 months, and really has had almost no extreme side effects. We might get a little injection site redness, a little bit of subjective feeling, a little bit foggy, but those are typically as much as we've ever seen in terms of side effects. And then the other thing I should mention is that, that this has a relatively fast excretion from the body, but some of those effects on the immune cells can last weeks and upregulate those natural killer cells, and some of those cytotoxic T cells can happen for easily 2 weeks. And so that's the Thymosin alpha-1. I couldn't spend enough time on it, honestly. There's so much stuff that can be said about this, but I definitely wanted to give some of the other products I mentioned as well. One of the products is Selank, and people might know Selank for its different effects beyond immune modulation. But Selank is part of usually a group of 2 peptides often talked about in Russia as the nootropic peptides, the Selank and the Cmax. And both of those were created with one idea, which is that how do we take a natural molecule and make it extend its duration, particularly extend its duration in the central nervous system. And so ACTH was what they chose for Cmax, but what they chose for Selank was essentially a small peptide from the IgG fragment which is Thymosin. It's a small amino acid molecule made of 4 amino acids, and they complex it with 3 additional amino acids to make it a little bit better. This sort of goes into some of its central nervous system effects and what they did in order to make it a little bit more resistant. However, in addition to its anxiolytic effect, I should say, in addition to its effect with Thymosin, it also has a great central nervous system effect. Most people know this because it has a really good therapeutic effect on anxiety. Most people within just an acute administration of this, within 5 to 10 minutes, will see a relaxation of anxiety and sometimes pain as well. And that's due to its mechanism of action, which is via inhibiting some of these enkephalin degrading enzymes and being able to help in the opioid system. And so one of the other things I should mention is Selank does a lot of different things, everything from affecting metabolic tissue to affecting GABA transmission. And so it does a lot of things, but it also has a great effect with antiviral help. It has a couple of really good studies, extrapolating from Thymosin as well, showing that it can help with herpes simplex type 2, CMV, many variants of influenza and other respiratory viruses, and that this can be used both prophylactically and in the case of some of these things like herpes simplex can actually be used to treat and reduce viral titers. And so this is another one which can be used both prophylactically and as treatment and has very, very little side effects. And so, one that people don't often think of, but one I definitely wanted to mention as well. As I go there, the typical dosing of this, unlike most of these peptides, the Selank is actually more bioavailable as a nasal product. So we would actually recommend this around 750 micrograms to 1.2 milligrams nasally, and that's usually once per day. Oftentimes, if people are using it for the clinical effect of anxiety, they might do it twice daily at 750 micrograms, which would just generally be around 1 spray into each nostril per day. And so again, this is one that has a lot of different effects, but it's another one that can just be added as a daily regimen to help with immune stimulation and modulation. These next 2 products that I want to mention are the Pentosan Polysulfate and the Thymosin beta-4. In addition to the effects that I mentioned, some of these immune effects, which I'll go over, I also want to mention that both of these are extremely anti-inflammatory and have direct effects on things like heart tissue. And so whenever we start to consider some of that cytokine storm that you see, which causes a lot of these unfortunate negative effects, the Thymosin beta-4 and the Pentosan Polysulfate can both have a couple different effects, which is, the anti-inflammatory effects, particularly on cardiac tissue, which is the #1 comorbidity, as well as its effects from a viral standpoint. And so the Pentosan Polysulfate is an FDA-approved oral medication with anti-inflammatory properties, which is generally used to treat interstitial cystitis. And so it's been used for that for years, but had a relatively popular revival over the past 5 years due to its effect on its pro-chondrogenic effects and its anti-inflammatory effects. So particularly for the use of, in osteoarthritis, with some of the results being pretty substantial. This is a study done in Australia from Paradigm Pharmaceuticals on the right, which shows the Pentosan Polysulfate's effect versus just the placebo effect. And obviously seeing many good results and high reductions in pain despite despite even ending treatment, even 4 or 5 weeks prior. And so again, this is great for a lot of different things that are inflammatory conditions, not just OA, but also things like intervertebral disc degeneration, and typically is dosed around 2 milligrams per kilogram twice weekly. So just like the Thymosin alpha-1, it's not one that you have to do every day, even though it is a subcutaneous injection. And we would still recommend it as a subcutaneous injection for its ability to help with some of the inflammatory conditions. But as part of its class, it also has some really good data as it relates to its inhibition of things like COVID-19 or the SARS-CoV. And it does this because the polysulfates on this small molecule are actually positively charged, and as a result, they can sort of hide these viral envelope protein markers, which would inhibit that spike protein from fusing with the cell membrane and causing replication. And so polysulfates in general are good inhibitors of viral replication from everything like HIV, but would also have an effect in COVID-19. And so as we're talking about things that might help prevent both viral replication and as well as some of that inflammatory response, Pentosan polysulfate is high on that list. Here are a list of other studies which have been shown to help this in virus models, and in particular with the Pentosan. And so it has a lot of different effects. Really the only negative side effects of the Pentosan would be that it shouldn't be used long term. There are some studies now which are showing that multiple year usage, upwards of 10 years, have shown to cause retinal damage. And so as a result, we would not recommend it for the long term. And beyond that, it does have some blood thinning effects. So if someone's on a blood thinner, this would not be something to be used. And although this says BID, it is 2 milligrams per kilogram twice weekly, not BID. And again, that one has been very, very popular for us in a variety of ways as well. The last one I want to reference is the Thymosin beta-4. As I mentioned earlier, the Thymosin alpha-1 and Thymosin beta-4 were discovered generally around the same time from Dr. Goldstein at Albert Einstein Medical School. And the Thymosin beta-4 has at least originally, a very different effect on as a mechanism of action. It's one of the most pleiotropic peptides we have because it affects so many different things. But most people would associate it with its effect on healing and reducing delayed onset muscle soreness. And so it's great for ligament, for injuries. It's an actin monomer sequestering protein. It has an anti-inflammatory effect. It recruits stem cells and it recruits blood vessels. And so usually it's the first gene and peptide to be expressed in any wound or tissue bed. And so that goes to show you just how the body uses it to help with repair and recovery. And it does a lot of things. It's anti-inflammatory, it promotes wound healing, and does a lot of things in between. And via a lot of mechanisms such as increasing IL-8 and MMP2 to attract stem cells to the injury, as well as increasing ATP synthase. So this is generally how it's used, athletic recovery, post-surgery injury, hair loss, cardiac, TBI, lung inflammation, and corneal healing. But it's used even beyond that. It has a direct antiviral effect. This particular antiviral effect to increase natural killer cells is actually very similar to the same effect that the Thymosin alpha-1 has via increasing interferon gamma. But this increases interferon gamma via the mechanism of increasing IL-18 and has a lot of really good data in a lot of different viruses. One of the most exciting studies actually showed that just a single injection of Thymosin beta-4 once weekly over the course of 12 weeks caused 26 patients, 26 out of 26 patients, to have viral levels of HIV be upwards of 250,000 and go undetectable in a 12-week period. So we know it has a great effect with HIV and might be something to consider for those patients, but generally is an antiviral product and peptide that has a lot of effects across different types of viruses because it's having this effect via a natural killer cell mechanism. And it might be having another effect via another mechanism. As I mentioned, it has so many different mechanisms, it's hard to tie back what is happening via what mechanism, but this is a one that is sort of a broad spectrum product to help with different viruses. For this one, the dosing is slightly different. It is going to be a daily subcutaneous injection. Usually the recommended dose is around 750 micrograms. One thing I should note with the Thymosin beta-4 is it's been given IV at up to 1.2 grams. And so this is still a relatively small dose and can be titrated up depending on presentation. The other thing I should note is that Thymosin alpha-1 can also be given IV, but usually it's been given IV in the same type of dose, generally 1.5 milligrams or 3 milligrams once or twice a week. And so the Thymosin beta-4 would just be a daily injection, usually for a short course. Because it is so angiogenic, and it's one of the ways that it helps with the healing process, obviously it's also thought that it might proliferate any type of cancer if it were present. And so usually courses are kept very, very short, and people who have a history of cancer, especially within the past 5 years, are really not encouraged to use this product. And so it does have some effect, but it does have a little bit more of the contraindications. And so that was sort of a quick just summary of all the different products, all the peptide products, which we're seeing pretty often. I already mentioned the masks as well, which would be available as the KN95 mask. But I also want to just briefly mention some of the things that we're seeing with things like statins, some things we're seeing like ARBs, which we're seeing increased prescribing of just due to this. And I can say that generally most of the infectious disease guidelines don't recommend starting things like statins or some of the ARBs, but we are seeing increased presentation of those. The other one that we're seeing increased presentation of is the PDE5 inhibitors, particularly tadalafil or Cialis. There have been a couple studies which have shown that increased nitric oxide can reduce viral replication of the SARS-CoV family. And so people are also supplementing with around 5 milligrams of daily tadalafil. And so that's something else that we've seen and has been, I would say, not thoroughly proven to help, but might theoretically help. On the note of the nitric oxide, in addition to having just increased nitric oxide in the system, having antiviral replication, there's also been some studies just cellularly showing that it also can reduce viral replication. But I can note that in studies where nitrous was inhaled to help alleviate some of the symptoms of this type of lung disease, symptoms were improved, but it showed no difference in the clinical outcome. And so it might be something to consider for patients who are having hard symptoms, but would probably not be something that would really affect this going forward to the future. So with that, I will open it up to Dr. Herskowitz for anything I might have missed. I know he's an expert on many of these peptides, and would like to turn it back over to him.
Thank you very much, Ryan. So to the audience, I told you that Ryan is an encyclopedic set of knowledge. So thank you, Ryan. So I would say a few things based on what you said, Ryan. I think thymosin alpha and beta and are sort of fundamentals. The Pentosan is very intriguing too, and but you know, when you talk about let me use Viagra, let me use tadalafil, let me take an antihypertensive drug, that's not a strategy. Okay, we need a strategy, and the strategy, and right now, if I had a guess, an educated guess, I'd say if you wanted to modulate your ACE2 receptor, then do it with vitamin D, because we co-evolved with the sun, and let's go with what we know for hundreds of thousands of years. So let's go with that. But I do want to say that hello?
Well, sorry, I don't mean to interrupt, but on that topic, you know, one of the peptides I didn't mention was the LL37, and it just so happens that you know, the LL37, this natural human cathelicidin process, is actually regulated by vitamin D production. And if you don't have enough vitamin D, then you can't have that process. And so I would absolutely agree with you that that vitamin D point is a good one and a way to even optimize your natural production of that product.
Right. So whether you're twisting or teasing a single receptor that it's a master receptor, which is what we're explaining, we can have a compound, in this case a peptide, grow collagen or grow cartilage, and also be an anti-inflammatory and be an antiviral, and you know, sometimes even be an antihypertensive because of its anti-inflammatory effects. You realize that you're dealing with a system. So the question is, we've been working together, as you know, Ryan and I have been working together on sort of fundamental drivers of repair. And so I want to finish with a few minutes on the master driver of energy in the system, because ultimately this will help us modulate our immune systems and be pro-repair. So if we have this concept of what's the driver of all of our energy? It's the mitochondria, and I'll show you a photograph of it in a second. But the concept is, if you want to increase your health span, in this case, you'll notice on the bottom, we have to add infections now and pneumonia-like illnesses to allow us to live what we would consider not only a high quality of life, but a lifespan that's healthy over time, because we need to not only prevent diseases, we have to diagnose and repair them over time, and that will give us a health span. So it comes down to these, the fuel cells of the body are called mitochondria, and the structure is this Christie structure, which contains all the energy cycles of every cell of the body. And so the concept is sort of if our mitochondria are healthy, so are we. So there is a compound that we've been working on together, producing ultimately an investigation review board application to study the effects of a compound that can communicate directly with the mitochondria and make these cristae from an aged wider stance into a crisper, less widened stance. So it makes all the transactions that are occurring here on the trillions per second level more efficient. So ultimately, you can turn a young mouse that is then, this is what they look like, and then later on in life they have this appearance, and then you can turn them back to a youthful position. So the concept of even going up one level, even a higher level of repair, is all about the system biology approach. So you realize that there are receptors. In fact, this virus has exposed the issue of one receptor having effects on every system that's linked here. So it's an immunological one, but it's also metabolic. All these factors go into not only aging, but has been exposed even with COVID-19 as a system-wide effect. But I think we'll be describing our collaboration together with me producing this IRB study over time, over the near future. So that I'll ask everyone to look out for that. So again, to summarize, we need a way to get out. We need to either catch the virus and remain asymptomatic, or low levels of symptoms, and we do that by being immunomodulatory. But that is the same thing, and I hope everyone understands now how an antiviral approach is pro-repair and pro-metabolic strategy. It's an anti-aging strategy. It happens to be focused on, let me prepare my system to handle an inflammatory state more elegantly, but this is the lessons learned here from this virus. And we also need these drug therapies to be completed, published, and made available, so that if we get a cough and low-grade fever, and we now want to be treated, we can do so safely and productively. So I'm going to finish off here. This is a set of informations that you could look into, and we'll make some of the slides available to all those participants. But now I'll hand it off to Jordan, and we can handle questions.
Yes, sir. Thank you, Dr. Herskowitz and Mr. Smith. We do have a great question here. So the question being, so are peptide medicines currently being prescribed by doctors, or is it still too novel and doesn't have FDA approval yet? Will there ever be a generic peptide medicine available over the counter?
And do you mind if I start that, Dr. Herskowitz?
Please.
Yeah, so the products I mentioned today, the Thymosin alpha 1, the the Pentosan Polysulfate and the Thymosin beta-4 are all FDA-approved products and are prescribed via physicians on a patient-specific basis to their patients. There are some, I would say, some over-the-counter peptide formulations which are coming to market, but most of these things are under investigational new drug applications, and most pharmaceutical companies are exploring these with a heavy investment. And so the majority of them probably won't be as widely available outside of the traditional prescription system.
I'm in agreement with that. So right now it's a prescription only concept.
That was kind of one of the main questions that we had. So I think that will about wrap it up for us here. And unless you have anything else to comment.
I want to thank Ryan for his time and for all of his efforts. I know FDA is coming down hard on compounding pharmacies to comply with the manufacturing guidelines, and I think TAILOR MADE is one of the few entities that we truly trust and talk about and use on a daily basis. So I'm proud to be a practitioner. I have no financial interest in this, so that's not the issue, but I think I'm glad to have partners like you guys around that also answer our questions in a timely fashion, because these are complexities, and ultimately we need to layer different things, whether it's vitamin C with vitamin D on the whole food side, or it's these complex peptides towards a specific goal. I want to applaud you guys for that, and thank you, Jordan, and Jan, thank you, ACAM, for sponsoring this webinar. And I do want people to go to the ACAM site and to look at all the different materials that we have on COVID. You can also find them on basically a parallel track on my site, but I also invite you to use this other site down the bottom that will allow you to look at the data in a practical way that you feel would give you the most information. So thank you very much and have a great day. Bye-bye.
Thank you.